Welcome to the deep dive. Today, we're getting into something really important in vascular surgery: how doctors fix aneurysms, those bulges, in the lower aorta and iliac arteries. You know, the main pipes down in your belly and legs.
Yeah, specifically using EVAR Endovascular Aneurysm Repair.
Right. And we're using the best source for this: Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition.
The gold standard, really.
Absolutely. So the mission today for you, the learner, is to cut through the complexity. We want to give you the key takeaways about these EVR techniques from the textbook, but in a way that, doesn't feel like reading a textbook.
Make it understandable, give you a shortcut to the core knowledge.
Exactly. We'll cover how these grafts work, how they stay in place, sizing, planning, the whole process, basically. Ready to jump in?
Let's do it. EVR is pretty remarkable. Instead of a big open operation, we use catheters, usually starting in the groin, to guide these fabric-covered stents, these endografts, right to the aneurysm.
And reinforce it from the inside out.
Precisely. Seals it off.
Okay, so the first thing that jumps out is, how do they stay put? With all that blood pressure pushing on them. That's fixation, right? Sounds pretty fundamental.
Oh, absolutely fundamental. Think about the force of blood, especially that systolic push with every heartbeat. It naturally wants to shove the graft downstream.
So fixation stops that migration.
Exactly. And the book talks about a few ways. There's what they call positive fixation.
Sounds direct. What is that? Hooks and things.
Yeah, pretty much. Tiny hooks, barbs. Some devices use anchors or even staples that actively grip the aortic wall. Really locks it in.
Okay.
Then, for grafts shaped like a Y, the bifurcated ones, there's columnar support. The structure itself, spanning across where the aorta splits, sort of wedges the top part in place.
Clever.
And then there's just friction. The outward force of the stent pressing against the artery wall helps hold it too.
So a combination approach, and I guess the tech has improved. Early ones maybe didn't have all this.
You got it. The early devices sometimes lack strong active fixation, and migration was a bigger concern. That's why pretty much all current endografts have some form of positive fixation built in now.
Makes sense.
Some even have this fuzzy polyester stuff on the outside.
Fuzzy stuff?
Yeah, it encourages your own body tissue, like a scar tissue, a fibrotic reaction, to grow into it. Helps lock it down even more. Your body helps secure the fix.
Wow. Now, the book mentions fixing it below the kidney arteries, infrarenal, versus sometimes above them, suprarenal. What's the difference in anchoring?
Good question. Infrarenal means the main anchor and seal is in that segment of aorta below the renal arteries. Supra-renal fixation often uses a bare metal stent, just the scaffold, no fabric that extends above the renals.
Why go above?
Well, that part of the aorta, the suprarenal segment, is often a bit healthier, maybe more uniform in shape, so it can offer a really solid place to anchor.
But there must be a catch. Why isn't it always done?
There's a trade-off. If, down the road, a patient needed open surgery for some reason, removing a graft anchored above the renals can be, well, a bit more complicated surgically.
Okay, that makes sense. So it's anchored. How does it actually seal off the aneurysm bulge, stop the blood flowing into it?
Right, that's the sealing part. The aim is a really tight, leak-proof connection between the graft fabric and the healthy aorta wall, above and below the aneurysm. Blood flows through the graft, not into the weakened sac.
And current grafts are designed for a nice, straightforward aortic neck shape, ideally.
Yeah, they work best in what we call ideal infrarenal aortic morphology.
But anatomy isn't always ideal, is it? What if the neck isn't perfect?
Exactly. That's where seal zone adjuncts come in. Extra tools.
Like what?
Things like special anchoring screws for extra grip, covered flares on the graft ends that expand out more, that polyester fuzz we mentioned, extra sealing cuffs, sometimes even using other stents off-label to help push the graft against the wall.
So a bit of a toolkit approach, depending on the patient.
Definitely. And the design of the stent at the very top of the graft matters too. How it's patterned affects how well it conforms, bends with the aorta's curves, especially in tricky necks.
Right, conformability. Okay, let's move down to the legs, the iliac limbs going into the leg arteries. Were there issues there early on?
Oh yeah, big challenges. Early designs often had limbs without full stent support. They could kink or even block off a occlude.
Not good.
Not good at all. So doctors often had to put extra stents inside those limbs, sort of off-label, to prop them open.
Using them in a way they weren't intended, does that cause problems?
It potentially could. The book mentions a risk of those extra stents rubbing against the graft fabric over time. Wear and tear.
Leading to?
Could lead to holes in the graft fabric itself, a type 3 endoleak. Blood gets back into the sac. That's serious.
Definitely. So how are the limbs designed now? Better?
Much better. Most current grafts have fully supported limb stents running the whole length. Gives much better patency, keeps them open, but, kinking can still happen, especially if the iliac arteries are really twisty or tight.
What makes the iliac anatomy challenging?
Several things. Any injury during the procedure, heavy calcium buildup, severe twists and turns, tortuosity, or even if the graft limb is just a bit too big for the artery, excessive oversizing, all increase the risk of problems like occlusion.
Got it. So sizing is critical everywhere, which brings us to overall sizing. Sounds like there are tons of options.
A huge range, yeah.
Yeah.
Different diameters for the aorta bit, different diameters for the limbs, different lengths. The tricky part is each specific EVAR system, each brand, has its own instructions, its own sizing windows, how it tapers, usable seal zones.
So it's not mix and match.
Not at all. Case planning gets complex. The surgeon really needs to know the specific device inside and out.
Makes sense.
Yeah.
What about the actual graft material? Is it special stuff?
It's usually polyester or PTFE, similar to what's used in open surgery grafts, actually.
Oh, okay.
But how it behaves inside is different. In open surgery, the graft gets incorporated by your tissues. With EVA, the stent graft is kind of suspended in the clotted blood within the aneurysm sac.
Suspended.
Yeah, in the thrombus. And because of that, sometimes fluid can seep through the fabric transudates or tiny holes, microfenestrations, might develop over time.
Huh. Any other material issues?
Well, there's potential for abrasion, the fabric rubbing against the metal stent struts. And the sutures holding the fabric to the stent can sometimes deform or wear. How they're attached varies too. Some are just sewn at the ends, others bonded differently.
Lots of subtle differences. Okay, how do surgeons see all this inside the body? Radiopacity, right? Making it show up on X-ray.
Exactly. The graft components are designed to be visible under fluoroscopy, that's real-time X-ray. But getting a crystal clear view isn't always easy, especially with portable C-arms or in larger patients.
So how do they manage? How do they see the crucial bits?
They rely on radiopaque markers. These are built into the delivery system in the graft itself. Little dots, rings, lines. They show up brightly on the X-ray.
And help with lining things up.
Precisely.
Yeah.
For orientation, knowing which way is up, deploying it accurately, and opening the gate for the second leg in those Y-shaped grafts.
But these markers aren't standardized, are they?
That's a key point. They vary a lot between devices, location, shape, number. And some parts might not be very visible at standard magnification. So again, you've got to know the specific device you're working with intimately.
It really emphasizes needing deep knowledge of the chosen device. Deployment precision sounds paramount. Are these things easy to steer in place?
The ease of use varies quite a bit. How flexible is the delivery system? How well does it track through potentially winding arteries? What are the sheath sizes needed? How precise is the actual deployment mechanism? It all differs.
And other factors complicate it too.
Yeah, things like how clear the labeling is, how well the device responds when you try to torque it, whether you need special wires, how tricky it is to cannulate that contralateral gate.
Right.
It all adds up. But ease of deployment is just one piece of the puzzle for overall performance.
So putting it all together, device characteristics, sizing, deployment quirks, how does a surgeon pick the right graft?
Graft selection is huge. It demands detailed knowledge of each device. The sizing rules, deployment steps, potential failure modes, published outcomes, how easy it is to fix problems later, the whole package.
Does knowing multiple systems help?
The book suggests it can be an advantage, yeah, especially for complex anatomy. Gives you more tools in the toolbox. But it also says mastering one really good system can work very well too, even for tough cases.
Are there devices better suited for specific problems, like tricky iliacs or short necks?
Definitely. For difficult iliacs, systems with smaller profiles or more flexible delivery might be preferred. For short aortic necks, some devices are just better designed for that, maybe needing less landing zone. And for really angled necks, while generally tough, there's the Aorfix device, which is actually approved for angles up to 90 degrees.
That's quite an angle.
It is. And sometimes surgeons use devices slightly off-label too,
I know.
using, say, an aortic cuff, or even a small thoracic graft piece for aneurysms very close to the renals, or for certain aortic tears, provided there's still enough healthy aorta to seal against. It's careful, considered use outside the main instructions.
And you mentioned aorto-uni-iliac graft, one leg only.
Yeah, that's an option. It's a street tube graft going down one iliac artery.
Mm-hmm.
You then block the other iliac and do a fem-fem, bypass a surgical connection between the leg arteries to restore flow.
When would they use that?
Specific situations.
Huh?
Maybe the aorta is too narrow at the bottom for a Y-graft, one iliac is completely blocked, or maybe fixing an old short body graft that migrated.
And for aneurysms really close to the kidneys, juxta or pararenal.
Right. For those, standard EVAR often won't work because there's no neck to seal in. That's where you get into fenestrated or branched grafts.
Custom jobs.
Often, yeah. Grafts with built-in holes, fenestrations, or branches to maintain flow to the kidney or gut arteries while sealing the aneurysm. Or techniques like chimney or snorkel grafts using parallel stents. Much more complex planning involved there.
Okay, so graft choice is key, but it all hinges on planning before the procedure. Preoperative sizing and planning sound absolutely non-negotiable.
Completely essential. Precise measurements, meticulous planning, that's the bedrock of success, short and long term.
And the main tool for that is the CTA scan, computed tomography arteriography.
That's the cornerstone. It gives detailed 3D images using X-rays and contrast dye. The book recommends specific slice thicknesses, thin slices, even thinner for the complex cases like fenestrated grafts to capture all the detail, usually done with IV contrast unless there's a kidney issue.
What are they looking for on these scans?
Everything. They review axial, coronal, sagittal views like looking at slices from different directions, plus those 3D reconstructions. They use special software for precise measurements, like centerline calculations that map the vessel's true path and length. Having good post-processing software is really vital.
And the old-style angiogram isn't typically needed for planning anymore.
Generally, no. CTA gives much more information about the vessel wall, thrombus, surrounding structures. Angiography has its place, but not usually for routine EVAR planning.
What about patients with kidney problems who can't handle the contrast dye? How do they plan?
That's a real challenge. Sometimes a non-contrast CT gives enough info, maybe on size and shape, especially in emergencies, but it makes it hard to see things like clot in the neck, which iliac branches are open, blockages.
So it's limited.
Very.
Yeah.
If the non-contrast scan shows lots of calcium, that's a warning sign you might have those other issues. Careful physical exam becomes even more critical then.
Are there alternatives if non-contrast isn't enough?
Yes. Intravascular ultrasound, IVUS, is one. A tiny ultrasound probe inside the artery lets you measure directly, see clot, check the iliacs. CO2 angiography uses carbon dioxide gas as contrast instead of dye. Or you can do a direct contrast injection into the aorta using a catheter, using a much smaller dose than the standard IV injection.
Minimizing the dye load.
Exactly. The book mentions a technique using wrist access transradial to place a catheter, then doing a limited CT or moving the patient briefly to CT using a tiny amount of dye mixed with saline. Can drastically cut down the contrast volume.
Okay, got the images. Now, the measurements. Let's start with the aortic neck diameter. How do they measure that accurately?
Super critical. Measure right at the lowest renal artery, then down 5 millimeter, 10 millimeter, 15 millimeter. Use the shortest diameter, the minor axis, on cross-sectional views. Or even better, use reconstructed perpendicular to the aorta's center line to avoid overestimating on angled slices.
And measuring wall to wall.
Usually outer wall to outer wall, adventitia to adventitia. But, and this is important, one device, the Gore excluder, was originally studied using inner wall to inner wall intima to intima. So for that specific device, you use the interval measurement. Shows you need to know the device specifics.
Definitely. So once you have the neck diameter, how much bigger should the graft be?
No oversizing.
Typically oversized by 10% to 20%. Usually means picking a graft diameter 3 to 4 millimeters larger than the measured neck. Devices generally cover necks from about 16 up to 32 millimeters.
Why oversize?
To get that tight seal against the aorta wall, prevents blood leaking around the top, that type IA endo leak. But you don't want to oversize too much.
What happens if it's too big?
Lab studies show if you go over about 20% oversizing, the graft fabric can actually bunch up, pleat. Those folds can prevent a good seal against the wall, paradoxically increasing the type IA leak risk. Might also stress the fixation points.
Wow, okay, so it's a balance. What if the neck isn't straight, but tapers? Conical necks. Yeah, conical necks diameter changing more than 10% or 2-3 millimeters over that first 15 millimeters are trickier. Size to the wide part, you might overcompress the narrow part. Size to the narrow part, you might not seal the wide part well.
So what's the approach?
Kind of split the difference. Choose a size that gives at least 10% oversizing at the wide end, but hopefully less than 30% at the narrow end. If the taper is really severe, though, standard EVAR might not be the best long-term fix. Fenestrated or parallel grafts might be better.
Okay, diameter down. What about length? How do they measure that?
Also crucial. Need the length between the landing zones. CTA reconstructions are usually pretty good for measuring from the lowest renal artery down to the aortic split, as long as the aorta isn't super twisty there.
But maybe less accurate further down in the iliacs?
Right. Standard measurements might underestimate the true path length to the hypogastric arteries if the vessels are tortuous. Centerline measurements might overestimate sometimes. It takes careful 3D review and experience with how grafts behave.
Would you ever choose longer iliac limbs than measured?
Yeah, sometimes. If the iliacs are really tortuous, if you plan to ballet or cross the limbs, which we'll get to, or if you need to extend way down into the external iliacs, slightly longer limbs can be safer.
And some grafts are modular, like building blocks. Gives flexibility.
Exactly. Modular systems like Cook Zenith let you adjust the overlap between components during the procedure to fine-tune the length. With Zenith, you typically aim for the contralateral gate opening to be about 1–2 centimeters below the aortic split. If unsure on main body length with modular systems, usually better to err slightly shorter.
When would you intentionally pick a shorter main body?
Maybe if the aorta is really narrow just before the split, less than 20 millimeters, or if there's a hard calcium ridge there, need to make sure the gate can open properly. The Medtronic Endurance 6S, with its shorter bodies and fixed limb diameters, was designed partly to simplify these length issues.
Okay, and sizing the iliac limbs themselves.
Also oversize, 10–20% over the minor axis diameter, usually 1–3 millimeters larger than a non-aneurysmal iliac artery.
And risk of oversizing there too, especially going into the external iliac.
Definitely. Too much oversizing in the external iliac increases risk of kinking, thrombosis. Best to land the limb before, or at least 15–20 millimeters beyond any sharp bends. And you want a good distal seal zone, maybe 2–3 centimeters long, in larger or tortuous common iliacs, as they can remodel after pressure is off. For really big common iliac aneurysms, might even need branched iliac grafts.
Okay, we've got planning, sizing. Now, who is actually a good candidate for EVAR? Patient selection.
Absolutely critical. It all comes down to that detailed preoperative anatomy assessment. The aortic neck length, diameter, angle, shape is the single biggest predictor of long-term success.
What are the typical ideal neck stats?
Most device instructions aim for a neck length of 10–15 millimeters or more and an angle less than 60 degrees. But there are exceptions. Endurant with endo anchors can go shorter, down to 4 millimeter. Aortics can handle angles up to 90 degrees. Max neck diameter is usually around 32 millimeter.
And the ideal shape?
Ideally, parallel sides, no big clots stuck to the wall, no heavy calcium. Irregular shapes, conical, reverse conical, double bubble bulges, have a higher risk of seal problems, endo leaks.
Is it usually one bad feature or a combination?
It's often the combination that's most problematic. A single adverse feature might be okay, but multiple challenges in the neck really increase the risk. An angled neck might be fine if it's long and smooth. A shorter neck, 10–15 millimeter, might work okay initially if everything else is good, but the risk of late neck problems, type IA leaks, might be higher, especially if it's also wide or angled.
So if the anatomy is way outside the guidelines,
then outcomes are compromised. Necks shorter than about 10 millimeters are usually better suited for open repair or complex endo like fenestrated or parallel grafts.
Okay, let's get into the procedure itself. Anesthesia, access, imaging.
Right. Anesthesia can be general, local with sedation, or regional general for open access. Key is controlling breathing, either patient cooperation or the ventilator. Local sedation is possible, even for ruptures sometimes.
And getting into the arteries, access.
Two main ways for femoral access in the groin. Open surgical cut down or percutaneous puncture. Percutaneous is much more common now, less invasive.
But not for everyone.
No. Contraindications include lots of groin scarring, high femoral split, needing lots of sheath exchanges, bad iliac blockages, very small arteries, or heavy calcium right on the front of the artery where you'd puncture.
So for those folks, it's open access.
Yeah. Vertical or oblique incision. Vertical might give better exposure higher up, maybe better healing if kept above the crease. Oblique often have fewer wound issues, especially in heavier patients.
What if the iliac arteries themselves are blocked or narrow? Can EVAR still happen?
You just spot that on the CTA. Short blockages can often be treated with balloon angioplasty just before inserting the graft. Try to avoid stenting before putting the big sheets through, as they could displace the stent. If a stent is needed outside the graft area, usually do it at the end.
Any other tricks for tough access?
Can use slippery hydrophilic dilators to gently open narrowings, but need a stiff wire for support. Maintaining wire access is crucial. There's also creating an internal endoconduit, placing a covered stent in the external iliac, then dilating it aggressively to make a path. Needs good seal zones above and below, though. And sometimes a surgically placed iliac conduit sewing a two-graft higher up and bringing it down is the best bet for really bad calcium or tiny arteries.
And good imaging during the procedure is key.
Essential. High-quality fluoroscopy. Hybrid ORs with fixed imaging systems are increasingly common, especially for complex cases.
Even positioning the X-ray machine matters.
Big time. Angling the gantry to match the aortic neck angle is vital for precise proximal deployment. Often need cranial tilt, angling down because necks often tilt forward. Oblique views, LAORO, help pinpoint the lowest renal artery origin.
Okay, access sorted, imaging ready, time to deploy. First steps.
Guide a soft J wire up. Exchange for a stiff wire into the descending thoracic aorta. Careful not to go too far into the arch. Mark the distal end. Place a pigtail catheter above the renals via the other side. Maybe do a quick iliac angiogram if needed, but usually avoid a full aortogram before insertion, as the device can shift things slightly in tortuous aortas.
And the graft itself. Prep.
Examine it outside the body under fluoro first. Check markers. Orientation, especially the contralateral gait direction. Rotate it gently while advancing or withdrawing over the stiff wire. Don't twist when stationary.
What if it gets stuck going up?
Try an even stiffer wire first. Often works with modern trackable devices. Check iliac anatomy again. If still stuck, maybe a buddy wire from the other side to help straighten the path.
Now the critical moment, deploying the top end near the kidneys. How's that done precisely?
Fine-tune the fluorogantry angle. Cranial oblique. Magnify the view. Center the lowest renal. Power inject contrast to see the renals clearly. Aim to deploy the top fabric edge within 2 millimeters below the lowest renal orifice. Maximize seal length without covering it.
What about devices with that bare supra-renal stent?
Right, that often deploys first, anchoring it. Once that's out, you usually can't move the main body up anymore. The Gore C3 excluder is different. No suprarenal stent, allows some repositioning after partial deployment.
And if the graft covers a small accessory renal artery?
Generally okay in patients with normal kidney function. Don't usually treat it beforehand. More complex if kidney function is already poor. Might consider fenestrated grafts or open surgery then, weighing risks.
Main body deployed. Now, finding that contralateral gate for the second leg, tricky.
Can be. Usually accessed retrograde from the opposite groin. Planning gate orientation before deployment based on CT angles is key. Often aim at slightly side in front.
And that balleting or crossing limbs technique.
Yeah, with shorter body devices like endurant or excluder, sometimes rotating the gate to the same side as the first deployed limb helps access, especially if the contralateral iliac takeoff is wide or there's lots of thrombus, or the aortic bifurcation is wide side to side but narrow front to back. Check wire angles if they cross sharply. Crossing limbs might be easier and reduce kinking risk. Not usually done with longer body grafts like Zenith.
What are some maneuvers to speed up finding the gate?
Try not to pull the wire way back after removing the pigtail. Use steerable wires, angled catheters. Position the contralateral sheath near the gate for support. Use oblique fluoro views. Try different catheter shapes. Steerable sheaths can be lifesavers in tough cases.
What if you just cannot get in from below? Backup.
Rare, but can try antegrade access from the arm, brachial or radial. Get a wire through from above, snare it from below. Absolute last resort is converting to an aorto-uni-iliac configuration, block the gate, do a fem-fem bypass. Bailout maneuver.
Okay, gate cannulated. Deploying the limb down the iliac artery, how to position it correctly.
Do a quick angiogram through the contralateral sheath to see the distal landing zone, especially the hypogastric artery takeoff. Use oblique views. Need adequate overlap with the main body, minimum 2 centimeters in straight vessels, more in tortuous ones. Avoid landing right on sharp iliac bends.
What if a limb kinks or narrows after deployment?
Treat promptly with balloon angioplasty. If still narrow, maybe place a self-expanding stent inside the limb. If the bifurcation point is tight and compressing both limbs, sometimes simultaneous balloon inflation in both kissing balloons helps.
And using molding balloons, what for?
Use compliant balloons at the aortic neck, the limb connection points, and distal iliacs. Presses the graft against the wall for optimal seal. Crucial not to inflate beyond the graft material risk of rupture.
Final step. Completion angiogram. Check the work.
Absolutely. Inject contrast above the graft. Check renal and hypogastric patency. Graft deposition top and bottom. Look for distal iliac disease. And crucially, check for endoleaks, any flow still getting into the aneurysm sac.
And if there is a leak then?
Specifically, look for type 2 leaks from side branches. Can sometimes treat immediately with coils or glue embolization going through the vessel or behind the graft. Sometimes needs later treatment or rarely surgery.
So even with perfect technique, issues can pop up. Troubleshooting is part of the game.
Definitely. Need to be prepared for intraoperative and postoperative problems. It happens.
The chapter referenced some key studies, too. Any quick highlights?
Yeah, they covered things like open versus percutaneous access outcomes, how neck diameter affects long-term durability, EVAR with versus without endo anchors for extra fixation, long-term Medicare data comparing EVAR and open repair, and the 5-year results for the endurance graft showing good performance. All important context.
Well, this has been incredibly insightful. It's really clear just how much goes into EVR. It seems minimally invasive, but the planning, the device knowledge, the procedural skill, it's immense.
It truly is. From picking the right device for that specific patient's anatomy, the meticulous sizing, navigating deployment, handling potential issues, it's complex work.
It really underscores the expertise needed for this kind of vascular repair.
And the field keeps evolving, doesn't it? Devices get better, techniques get refined, all aiming for better long-term outcomes and wider applicability.
So for you, the learner, we really hope this deep dive has given you a solid grasp of the intricacies of EVAR. And here's a thought to leave you with. Given how fast this technology moves, what future innovations do you think will most significantly boost the durability and reach of EVR? Something to ponder. Maybe check out those references or related research. Thanks for joining us.